So we are talking about immune-mediating necrotizing myopathies, and we will see how this is a new category of muscle disease recently discovered by the fact that new autoantibodies were previously identified. Basically, autoimmune myopathy are a group of heterogeneous diseases that were defined in the mid-70s, and the autoimmune myopathies were defined by bilateral muscle weakness. The muscle disease is attested by either an increase of CK level, either myopathic changes on EMG. The autoimmune-mediated pathophysiology is attested by the presence of inflammation within the muscle tissue, and we make afterwards the distinction between two categories of muscle disease, the ones with skin rash, namely dermatomyositis, and the ones without skin rash, polymyositis. In fact, polymyositis is probably a heterogeneous group of disease. Recently, in 2017, EALLER and FAI²R make new recommendations for defining autoimmune myopathies, and in addition, they try to refine the classification of myopathies. And finally, the new classification leads to only 3 subgroups of patients. One group is DM, amyopathic DM or juvenile DM, but DM, and 2 other groups, one is inclusion polymyositis and the other one is polymyositis. But between the mid-70s and until now, it was recognized and identified at least 15 myositis-specific antibodies. And we will see how these antibodies permit to identify a new subgroup of myopathies among the group of autoimmune myositis. In fact, the new antibodies were able to fish or to immunoprecipitate the group of immune-mediated necrotizing myopathies. The first specific antibodies associated with necrotizing autoimmune myopathies were described in 1986. It was anti-SRP, and in the group of polymyositis, these antibodies were described for the first time. It was needed years and years, and this landmark paper made by Fred Miller at the beginning of 2000, where he collected a case series of patients with polymyositis with anti-SRP antibodies. And he looked carefully what happens within the muscle tissue, and he was able to observe that in muscle tissue there is a lot of different size of muscle fiber size, with variation between different muscle fibers and with atrophy. And in addition, the main feature was presence of necrotic muscle fiber or regenerative muscle fiber, whereas inflammatory infiltrates were mild or absent compared to myositis GO1 positive or polymyositis GO1 negative or dermatomyositis patient. The year later, a Congress of European people based on neurology and myopathologies refined the classification of myositis. And for the first time, after the paper of Fred Miller, they defined a new group of myopathies, immune-mediated necrotizing myopathies, and this new group was based on a pathological definition, including mostly necrotizing muscle fiber and regenerative muscle fiber, whereas the infiltration within the muscle were mild or absent. So this new entity was described at that time and associated with anti-SRP. In 2008, the team of Andrew Maman defined, analyze, retrieve a group of immune-mediated necrotizing myopathy IMNM based on the pathological definition that we just have shown. and look the possibility of new antibodies within this group. He retrieved the presence of anti-SRP, but he was able to identify a new antibody, able to recognize a protein of 1 kilodalton weight. Next, he was able to identify the target of the antibodies. This antibody finally recognized HMG-CR enzyme within the muscle cells and in cells. And this target was identified because when he looked at the characteristic of the patient positive for these new antibodies, he observed that most of the patients were statin exposed before, and this observation led him to think about the hypothesis that the target of the antibodies could be HMG-CR. So probably these two antibodies clearly permit to identify a new group of myositis, IMNM patient, and this is a group different from polymyositis patient. Recently, the team of Olivier Benveniste and us, with Marion Pillet, were able to make an analysis of a large group of myositis patients in France. She finally collects roughly 250 cases of patients, and for each patient, she analyzed 15 variables defining a patient based on the epidemiologic characteristic of the patient, based on the muscle feature and extramuscular features, and including the results of muscle-specific antibodies testing. Next, she performed unsupervised analysis of this group of patients, and she was able to observe that the patient clustered in 4 different categories, and these 4 categories were the following. In fact, if we analyze the patient and we represent on this factor map the patient, each dot is a patient, and the place of a patient and the dot is depending on the variables associated with the phenotype of the patient. We were able to show that the 4 categories of the patient were different. And when we look at the categories of the clusters, finally we found a red cluster, and the red cluster was mainly patients without any other extramuscular manifestation, with important muscle necrosis within the muscle tissue, and patients were positive for either SRP or HMG-CR antibodies. Though then this appeared that IMNM is an independent group of myositis different from IBM patient, DM patient, and antisensitized syndromes. So clearly, the antibodies permit to fish among autoimmune myopathies a group of IMNM, and we will next see what are the characteristics of SRP positive patient, HMG-CR positive patient, and there is a remaining group of IMNM patients negative for these both antibodies. Basically, IMNM patient, either SRP or HMG-CR antibody positive patient, could be young people like elderly people. There is juvenile cases of IMNM patient as well as elderly patient. Most of the cases have an onset around the 60s. Usually the disease starts with an acute onset or subacute onset within weeks and months. Patients have a weakness, usually a severe muscle deficit, frequently associated with myalgia, and usually the CK level is really high. This represents roughly 2/3 at least of the patient, but there is another phenotype of patient with a slow disease onset. These patients are not commonly seen in rheumatological department, but basically in neurology outpatient clinics. And this patient mimics dystrophy disease, genetic disease, since it could happen especially in young people. And now we know that for patients with genetic features and slowly progressive muscle disease in young patients, it is worth to test these antibodies to be sure that this is not a mimicker of muscle dystrophy. We want to also insist about the fact that HMG-CR patients are frequently exposed to statin exposure, which can lead to the occurrence of the disease. This is mainly the case for elderly people after the age of 60 years old, and roughly in the whole population of HMGCR patients, the statin exposure is roughly a half of patients. When we look at the muscle tissue, the main feature is the presence of necrotic muscle fibers, and this feature occurs within the whole muscle tissue, randomly distributed within the muscle tissue. This is true for SRP patient and HMGCR patient. Necrotic muscle features are not specific of IMNM patient. They can occur in G1 positive patient, but that time the necrosis are clustered in perivascular area of the muscle tissue. Usually DM patients do not have muscle necrotic fiber, but it can happen, but again, usually it occurs in perivascular area. Finally, necrotic muscle fiber is a rare event in IMNM patient, and indirect sign of necrosis are regenerative muscle fiber. And when we test the expression of marker of regenerative muscle fiber at the bottom line, we see that there is much more frequent regenerative fiber in IMNM patient than necrotic fibers. And again, the topography of regenerative muscle fiber is randomly distributed within the whole muscle tissue, whereas it is clustered in perivascular area in anti-satiety syndromes. At the opposite, there is very mild or no inflammatory infiltrate within IMNM patient. Looking at the T cell density, we saw that as T cell density were low in IMNM patient SRP or HMGCR positive compared to G1 patient or DM patient. But we must emphasize that when the necrotic features are very predominant, are important, finally at least we can observe frequently T cells infiltration. And at that time, in important muscle necrosis cases, presence of inflammatory infiltrates are not so rare, and they can reach the same T cell density than some G1 patient. So inflammatory infiltrate in IMNM patient may occur in severe cases. When we look at the prognosis of this patient, the team of Mamen show that this patient had a poor prognosis, especially for SRP patient. When you look at the muscle strength recovery 4 years after the disease onset, you observe that at least just a half of patients recover normal muscle strength. For HMGCR patient, this is the same, especially for patients younger than 20 or 40 years old. At the opposite, patients older than 60 had a better prognosis. Why this patient had worse or poor outcome or poor prognosis? It is because when we look carefully in the tight muscle MRI, and this work was done in US with Lisa Christopher-Stein, they show that IMNM patients have more muscle damages compared to other group of muscle disease. Patients with IMNM have more frequently muscle atrophy or fatty replacement compared to other myositis such as DM patient. Concerning the extramuscular manifestation of IMNM, finally there are few and not so many. The only one who had clearly extramuscular feature is anti-SRP patient. Anti-SRP patient may have a cardiac involvement. There is no clear prospective study permitting to well precise the cardiac phenotype of the patient, but previous series reported regularly a cardiac involvement in SRP patients. And we know that some patients had severe myocarditis, and it is necessary for all SRP patients, at least at the beginning of the disease, to check if there is no sign of myocarditis, checking muscle, cardiac enzyme, performing ECG or cardiac MRI. At the opposite, HMGCR patients do not have any cardiac involvement reported frequently until now. For the lung involvement, it was reported since few years that patients may have interstitial lung disease, and roughly 50% of patients may have an ILD, and that time the ILD is not severe, and the patient had do not have any clinical involvement. This is not a severe lung disease. Concerning HMGCR patient, there is no frequent or rarely report ILD in patient, and today ILD is not a common feature of HMGCR patient. Concerning the malignancy associated with myositis, it is well known that DM patient had an increased risk of malignancy. But meta-analysis also show that even if the risk is lower, PM patients have also an increased risk of malignancy. Since we know that PM probably encompasses both groups of patients, necrotizing myopathy and antitest syndrome, we focus on necrotizing myopathy because previous report described the association between malignancy and necrotizing myopathy. So to test the association between malignancy and IMNM patient, we performed a study combining patient positive for SRP, patient positive for HMGCR antibodies, and patient without any specific antibodies. And we observed that the frequency of cancer compared to age and sex-matched healthy population was higher in patients without any antibodies. We found that SRP patients have no risk of malignancy compared to general population, and we found a slight increased risk in HMGCR positive patients. This kind of study was also performed in Japan, and they retrieved the same risk, and in US it was also performed, and they do not confirm this observation for HMGCR patient, meaning that for HMGCR patient, the risk of malignancy is mild. Finally, IMNM patient is an homogeneous group of disease. We have just saw the picture of the disease. So we performed recently a meeting with European and American team to refine the definition of IMNM patient. We made a new definition of IMNM patient. In the following case, we say, if patients have clinical feature of IMNM with clinical phenotype with important muscle weakness, subacute weakness, with subacute onset and high CK level, this patient had probably an IMNM. And that time, we just have to look for the presence of specific antibody, either SRP or HMGCR antibody. And if the test is positive, the patient could be diagnosed as anti-SRP IMNM, either anti-HMGCR IMNM patient. And in that case, the muscle biopsy is not necessary anymore. And if patients do not have any specific antibodies, in that case, we need to perform a muscle biopsy to show that there is features compatible with the diagnosis, with necrotizing muscle fibers to define an IMNM without any specific antibodies. Concerning the pathophysiology of the disease, we know that there is necrotic, but the poor outcome of the patient is also associated with the atrophy of the patient, and when we look to the muscle features, we see that there is high number of small atrophic fibers, and we tested the pathogenic effect of these antibodies, of SRP or HMGCR antibodies. Here, this is muscle cells, this is the culture, and this is the control. And here, this is muscle cells exposed to serum of patient with SRP antibodies, and this is muscle cells exposed to serum of HMGCR positive patient. The first line shows that if we co-culture muscle cells and plasmapheresis from SRP or HMGCR patient, we observe a decrease of muscle growth and muscle atrophy. To rule out the possibility that cytokines within the plasmapheresis can explain this effect, we collected IgG from SRP and HMGCR patient, and we observed the same effect. To be sure that the effect was due to the SRP antibody or HMGCR antibody, we that time specifically collect the SRP or HMGCR antibody, and we retrieve the same effect, meaning that at least in vitro, the antibody SRP and HMGCR are pathogenic. and induce muscle atrophy. Come back to the vivo samples. We found that there is frequently C5b9 complement deposit at the surface of the muscle fibers. This complement cascade could be activated in several ways, and one way involve the antibodies. This is the classical pathway. This classical pathway involved the activation on C1q, and we were able to detect C1q deposition at the surface of the muscle cells, and we were also to detect the presence of IgG deposit at the surface of the muscle cells, meaning that the complement activation could be induced by immunoglobulins in IMNM patients. And since we observed that C5b9 decoration was associated with the proportion and the frequency of necrotic muscle fiber, we thought that it could be a pathological mechanism to explain the muscle necrosis within the muscle tissue of patients. To confirm the pathologic role of the antibody, a close team in France, led by Olivier Boyer in France, performed a study in mice where he transfected plasmapheresis or immunoglobulins for SRP or HMGCR patients into naive recipient mice, and he observed a decrease of the muscle strength in transferred mice, and the muscle pathological analysis showed that mice transferred with IgG from SRP or SRP, MGCR or SRP antibodies show a presence of necrotic muscle fibers, meaning that probably immunoglobulin from a patient leads to muscle necrosis, at least in mice. And to analyze the role of the complement cascade in this picture, he redo the experiment with mice without complement, C3KO mice, and he showed that without C3, it was not possible to induce any more the disease, meaning that the antibody needs complement activation to induce the muscle disease. We don't know how precisely treat this patient because there is no RCT permitting to well define the best way to treat this patient. Based on previous reports and especially on a retrospective study performed by the team of Mamen, we finally proposed that at the beginning, patients need to have rituximab for SRP patients in addition to high dose of steroids. We do not suggest to use rituximab for HMGCR patients at the beginning since the retrospective study we performed do not show clear efficacy of this approach. Frequently, patients are relapsing when we decrease the dose of steroids, and we know that IgIV play a key role to maintain the disease control. And recently, it was shown in New England Journal of Medicine that only treatment with IVIG without any steroids of immunosuppressant permit to maintain or to induce the disease remission for IMNM patients, at least for HMGCR patients. So to conclude, IMNM patient is a homogeneous group within the heterogeneous group of myositis patients. This group was identified based on the discovery of two specific antibodies, SRP and anti-HMGCR antibodies. This group was enlarged with patients with IMNM without any specific antibodies. This is a group of severe muscle disease. Most of the patients do not have extramuscular features except for seronegative patients who have a high risk of malignancy. Now these antibodies are a clear key diagnostic criteria for IMNM patients, and they probably play a key role in the pathophysiology of the treatment and involve complement activation.